So now we will be joined by our keynote speaker who will deliver a presentation titled Prevention is a Priority to Address AMR on a Global Landscape. This will be delivered by Dr. Ramanan Laxminarayan, who is joining us virtually from the United States. He is the founder, oh yes, sorry, go ahead. I'll give you a moment. Dr. Laxminarayan is the founder and president of the One Health Trust in Washington, D.C. and New Delhi, a senior research scholar at Princeton University and director of the World Health Organization's Collaborating Center on AMR. He is an affiliate professor at the University of Washington, senior associate at the Johns Hopkins Bloomberg School of Public Health, and a visiting professor at the University of Strathclyde in Scotland and National University of Singapore, Sa Sui Hawk School of Public Health. He is an outstanding researcher, educator, and AMR enthusiast. Really, I do not have enough time to share all of his accomplishments, and this introduction does not do him justice. To truly appreciate his impact and accomplishments, you can actually search him up on Wikipedia or listen to his TED Talk. Without further delay, I give the floor to Dr. Ramanan Laxminarayan, and I apologize if I said your name wrong.
Thank you. Thank you for that very kind introduction. As it happens, I'm in India today, but I'm glad that bioMérieux is supporting the 2024 AMR Symposium. So all my slides, you're welcome to take pictures or tweet it out. Nothing which is confidential here. So I was asked to speak on prevention, which is obviously a very important topic. And a lot of what I'm going to talk about, wherever you don't see a citation at the bottom, really comes from the 2024 Lancet series on antimicrobial resistance. Now, that is actually not the title of the series itself. The series itself, on its front cover, it talks about the need for sustainable access to effective antibiotics. And over the course of this presentation, I think it'll be clear where I'm sort of moving away from this notion of AMR being our biggest challenge. For a variety of reasons. It doesn't resonate with all audiences. It has less relevance in many parts of the world. And when you prevent disease, that's not just about AMR, you prevent all bacterial infections. So let's first start with the numbers. So every year we have an estimated 7.7 million deaths associated with bacterial infections. About 5 million of these are associated with AMR, but only about 1.27 are actually caused by AMR. The rest are just associations. Now, 7.7 million is a large number. Now, if you recall, in 2001 or so, when the Global Fund was set up and also the President's emergency program for AIDS relief in the United States was set up, PEPFAR, the peak number of HIV/AIDS deaths was about 2 million. Here we're talking about the problem, which is about 4x the number in terms of mortality, and that is all bacterial infections, non-TB bacterial infections. And if you add tuberculosis to this, which is another 1.25 million deaths, it takes you up to 9 million deaths. So far and away, bacterial infections are the biggest cause of deaths, certainly from infectious disease. They account for half of all infectious disease deaths. And AMR is a problem as a subset of that broader problem, and it has obviously been rising over time, and the projections from the OECD are that resistance to third-line antibiotics could be about twice as high in 2035 compared to 2005. And these seem kind of alarming, but I have to say that every time we make these projections, the reality ends up being worse than what was projected. So I don't think these are they are alarming, but they're not alarmist. The impact is highest, obviously, in low-income and middle-income countries, where the AMR-associated deaths, in terms of rates, are highest in certain parts of the world, sub-Saharan Africa being by far and away the highest. And that's natural, because that's where you have a huge burden background of infectious disease. But what we call AMR deaths are also conflated with two other factors. One is these are the places where prevention is weakest, which is why there's a high burden of infectious disease. Second, access to antibiotics is also weak, which means that a lot of people who are dying in sub-Saharan Africa would not die if they lived in Canada. They would have access to very different antibiotics. So access to effective antibiotics is really the big problem. AMR is certainly a manifestation of some aspects of this, but really if people had access to effective antibiotics, it would be very different and depending on where they lived. Now, AMR itself threatens progress towards goals on child survival and healthy aging. If you didn't have AMR, we would be sort of on track to reach our newborn mortality goals consistent with the Sustainable Development Goals. So basically, it makes a big difference whether you have a big problem of ineffective antibiotics or not. And if you look at the pathogens that are most common, you see that E. coli tends to be, number one. But all the others, Klebsiella pneumoniae, Staph aureus, pneumococcal pneumonia, are all important in various parts of the world. And you see all-cause mortality in people above the age of 65, which is the elderly population, being quite high in South Asia. And this is a problem for the Sustainable Development Goals on healthy aging. Now, what are we asking of antibiotics? This is crude infectious disease mortality in the United States in the previous century, going from about 800 per 100,000 per year down to less than 100. So that's a tremendous decline. But look at where penicillin was first introduced. Penicillin was introduced when the decline was already 3/4 of the way down, which means that the reason why we have lower infectious disease mortality in high-income countries in general is not because of antibiotics. It's because of public health departments. It's because of chlorination. It's because of just hygiene and having, just public health. And these are what are missing in many parts of the world. In South Asia today, crude infectious disease mortality rates today are about 400 per 100,000 per year, which is twice what it was when penicillin was introduced in the United States, twice today compared to 1942. Sub-Saharan Africa, it's 3 times as much. So in short, antibiotics are being used as a substitute for prevention and public health rather than as a complement. And the analogy is this is like mopping up your bathroom floor with the tap running. You'll never be able to do it. We have to stop the tap from running before we try to mop up the floor. And antibiotics are at best the mop. They cannot serve the purpose of public health, although we're trying to use it in that fashion. Now let's move to the other end. For those who hold out hope that AMR is a problem and therefore having new drugs is a solution, these are annual sales of selected antibiotics approved in the past decade. Now, you don't have to be an industry expert, but you have to know that if you've just spent about $500 million to $1 billion for a new antibiotic, just making somewhere between $20 and $100 million is just not going to cut it for you. The best-selling antibiotic is ceftazidime avibactam, so that's an outlier in a sense. But in general, antibiotics don't make a lot of money. So it's a losing business in general, and therefore we can't expect to see a pipeline which is going to be very full given that the economics are not favorable to new drug development. In fact, for every company that has developed an antibiotic, starting from when they got an FDA approval, their stock prices have gone down. This is unusual because typically when companies get a product approved, their stock prices go up. But in this particular case, they've not just gone down. Many of these, in fact, nearly all of these have gone bankrupt as well. And if you look at the number of antibiotics approved by the FDA, it has started going back up a little bit. But that's not entirely a positive trend because the numbers have increased, but these are not necessarily novel or useful antibiotics. And even when these drugs are developed, they don't reach the populations that need them. You can see that most drugs are reaching only, North America, and certainly, some parts of Asia, vast parts of Africa, and even parts of Europe don't really have access to the antibiotics. So it isn't clear that developing new drugs is going to be the solution here. And even when you look at trends in development of new antibiotics, we see that 61 new antibiotics approved between, say, 1980 and 2009, 43% were withdrawn either because of toxicity or lack of market. And this is much higher than the withdrawal rate for other therapeutic categories. So just having a new antibiotic doesn't mean we're going to solve the problem. And last but not least, the cost of these drugs is climbing. So if you see penicillin, that was probably 10 cents a dose. Linezolid, $155. Daptomycin, slightly more. cefiderocol, introduced in 2019, is about $4,800 in the US. Now, this is a log scale, and this is another drug which is not an antibiotic, it's not an anti-infective, it's used for cancer therapy, but it only improves your life, extends your life by 3 years if you have cancer, and the cost per month of this drug is $10,000, so it's $31,000 for the drug. And that is really the scenario towards which we're hurtling, and this is not in the future. This is the price of antibiotics, the new ones, introduced, and these are US prices, of course, but if you look at the prices before 2000, the prices are typically under, a couple of $100s. But if you look at after 2000, the prices of antibiotics are somewhere between, $5,000 and $15,000, especially if they're targeting gram-negative bacteria. Now, that's a very, very different space to be in, to charge patients that kind of money, but that is the kind of price that supports the development of a new drug. And so we're in a situation where the era of affordable first-line antibiotics is not closing, but it is something that we really need to pay attention to. And I think the point is simply that if we think we're going to innovate our way out of this space, this problem, simply by developing new antibiotics, I don't think that's going to work for most of the world, not even in high-income countries, not for the companies, and certainly not for the vast population in the low and middle-income countries, which are the ones that really need antibiotics. And we do see this as a divide between the agendas in the global north and the global south. These are very crude words, global north and global south, but it sort of conveys a certain sense, right? And I think the main divergence here is simply that AMR is equated to new drugs in high-income countries, but AMR is not the primary problem in LMICs. It is not the primary problem. The primary problem is insufficient prevention, whether through water and sanitation, through vaccines, or through infection prevention control. Second is access. People in LMICs simply don't even have access to existing antibiotics, let alone new ones. Third is drug quality. Many of the drugs that are sold in LMICs are just not, they fake, substandard, or counterfeit, and therefore that causes a lot of deaths. After these comes AMR. So it depends on who you're speaking with, and which is why the AMR agenda doesn't always resonate with people in LMICs. They don't see that as the primary problem. They see prevention as a primary problem, access is a problem, drug quality is a problem, and then AMR is a problem. So do we still think that we can outrun the bugs? I hope I've convinced you so far that that's going to be pretty hard to do, which means that we've got to turn to the other set of tools that we have, which are prevention tools. So these are numbers from the Lancet series, which show that we can reduce AMR deaths very easily, far more than 10%, but we can, by aligning IPC standards, which is basically making sure that IPC standards are those same as those in high-income countries, can prevent about 337,000 deaths. Access to wash services, mostly hand hygiene actually, reduces nearly 250,000 deaths. And high-priority pediatric vaccines can prevent up to 181,000 deaths. So in total, about 750,000 associated deaths that are avoidable each year through interventions that are easily scalable and are already well-known and understood everywhere in the world. So let's start with vaccines. What's the role of vaccines in reducing the burden of antimicrobial resistance? Well, to start with, vaccines have many values, right? So they reduce mortality, morbidity, they have effects on the microbiome, they reduce economic burden, they have equity and social justice issues, which they help with. But AMR is an important part of the full value of vaccines. And fundamentally, when you have vaccination, you have fewer infections, which results in lower disease burden. You also have less antibiotic use, which results in reduced selection pressure. But either way you look at it, you have lives saved, whether directly through reducing burden of disease or by having fewer antibiotics. And we've seen with pneumococcal pneumonia that vaccines can be very effective, reduces both susceptible disease and non-susceptible disease, and even in non-target populations. Now, what we did a few years ago, starting a few years ago, was then going back into existing data sets, trial data, estimated the value of vaccines on antibiotic resistance and use for a range of antigens. And what I'm about to show is a very quick snapshot of of this set of papers, which were published under a consortium called RVAC, which was supported by the Gates Foundation and was done collaboratively with the World Health Organization. Covers a range of existing and new vaccines. Now, we know that, say, for instance, diphtheria after vaccine introduction just drops off and never really recovers. So we know that vaccines are very effective. We also know that PCV7 introduction was associated with reducing antibiotic prescriptions and ambulatory care visits. So we have a lot of evidence from the pneumococcal vaccination story, not just in one country, but really in many countries. We also know that it's not just about bacterial vaccines. Viral vaccines can also avert antibiotic use. The peak month of consumption in the northern hemisphere is December or January of antibiotics. And in the southern hemisphere is June or July, which clearly indicates that antibiotics are being used for flu-like symptoms, because that's what the primary driver is for antibiotic consumption by a long shot. In fact, vaccines against viruses are very helpful. In the US, about a fifth of influenza patients are prescribed antibiotics, even though 3/4 of them, more than that, had no evidence of a secondary infection. Influenza vaccination reduced antibiotics prescribed to unvaccinated household contacts of vaccinated children by nearly 90%. That's an astounding effect, right? And even for Group E strep, the use of antibiotics has been blamed for the increase in Group E strep isolates resistant to clindamycin or erythromycin over the last 20 years. So overall, we can see that a lot of things are made possible if we had vaccines against viruses. And of course, GBS different. Now, PCV, avertible antibiotic use, we did this work, and pneumococcal infections caused about 57 million antibiotic treatment episodes in children under 5. And even with current coverage, PCV7, where PCV10 or 13 prevents about 24 million antibiotic treated episodes. And if we made this universal, we could avert another 22 million antibiotic treated episodes. Similarly, for rotavirus, we currently rotavirus infection causes about 48 million antibiotic treated episodes, but making this universal can increase or avert another additional 18 million antibiotic treated episodes. And these were all done using data from clinical trials, which were able to show what the difference was between vaccination versus non-vaccination in terms of prescriptions. Typhoid conjugate vaccines, we can avert about 342,000 deaths from MDR typhoid deaths over 10 years. And it's a significant impact on incidence of fluoroquinolone non-susceptible disease and also multi-drug resistant cases of typhoid. So with typhoid, we're now seeing the introduction of this typhoid vaccine in countries in response to MDR typhoid, like we saw in Zimbabwe and Pakistan. But it doesn't have to be reactive. It can also be proactive. And if we're able to use this in a clever way, we should be able to reduce the burden of resistant deaths here. Now, tuberculosis, we don't have a vaccine yet, but if we had a vaccine, which is like the M72 vaccine, which is currently undergoing trials, we could reduce deaths by about 119,000 or of rifampicin-resistant deaths between 2020 and 2035. And if we combine that with improvement in management of disease, that number goes up to nearly 500,000 deaths between that period, 2020 to 2035. Now, RSV is an interesting space to work in because obviously now we have far more RSV vaccines than we ever did, and just a few years ago we had none. In a study that we did based on trial data from Novavax. Now, Novavax had an RSV candidate vaccine which failed to meet its clinical endpoints for the disease itself, but they also collected data for antibiotic prescribing. And what we found was that the intervention arm infants had about a 13% reduction in antibiotic prescribing over the first 3 months of life compared to the placebo. And similarly, a vaccine efficacy against antibiotic prescriptions was associated with fewer lower respiratory tract infections. So this is about 17% reduction in prescriptions with LRTIs. And maternal vaccination prevents about 5 courses per 100 infants in LMICs, which is about 11% of all antimicrobial prescribing. Now, today, we don't have a behavioral intervention that can be consistently applied that can reduce antimicrobial prescribing by 11%. But we have a vaccine, and if this vaccine could be deployed, it would help both for the disease as well as for the prescribing. And like I said, this was for a vaccine that wasn't necessarily the most effective vaccine. I suspect that one of the other vaccines that is now approved may have an even higher effect size. And LRTIs do account for nearly 3/4 of all antimicrobial prescribing prevented by maternal vaccination. So this is what the data look like. They look kind of, these lines are sitting on top of each other. The blue is the placebo, and the red is with the vaccine. Slight reduction over the first 90 days of life for any diagnosis and also for LRTIs, but it does add up to a significant number. And it's true in any diagnosis, low and middle income settings, and also for LRTI diagnosis. So you see a fairly consistent gap between what you get with the vaccine and what you get without the vaccine. And this, like I said, is the effect that you see. Now, we don't have a Klebsiella pneumonia vaccine, but Klebsiella pneumonia is the leading cause of newborn sepsis, which claims about 1 million lives a year. If we had a hypothetical maternal Klebsiella vaccine, which could be given to pregnant mothers during an ANC visit and had coverage equivalent to maternal tetanus vaccination, we can probably estimate what proportion of these deaths we can avert. And we use data from 3 different data sets, CHAMPS, Barnard's, and NEWOPS, all covering various aspects of newborn mortality and survival. And what we see is that in many parts of the world, more than 5% of all newborn deaths can be averted with a vaccine like this, a Klebsiella vaccine, and particularly because Klebsiella is very hard to treat now with antibiotics. So the numbers are also pretty large, greater than 10,000 in countries like India, but still pretty significant in many countries in sub-Saharan Africa and Latin America as well. And resistant infection deaths is also high in terms of what you can really avert here. So globally, we could avert about 80,000 neonatal deaths and avert about almost 400,000 newborn sepsis cases each year, which account for about 3.4% of all newborn deaths. And the largest benefits are naturally in places with high burden of infection, Sierra Leone, Mali, Niger, and also in Bangladesh, where you could have vaccination avert about 6% of all newborn deaths. Again, we don't have the needle on newborn deaths has been, stuck for quite some time. And if we had vaccines as a way of preventing infection, we could reduce a lot of these deaths. So to summarize, if you look at the right side, this is a summary that WHO provided based on our studies and a couple more to look at the number of AMR deaths averted with vaccination. And a lot of these are already also in development. So either they're in, they are in various stages of development. So the blue is a preclinical and the orange is an active clinical. So some of these candidates, we do have some options here in terms of where they might be. So pneumococcal pneumonia, obviously, successful, but we still have other areas where we need to get into. Now, if you look at direct prevention through vaccination as a whole, this again is from the Lancet series. From new introduction, we have, these are thousands of deaths. We have probably, about 125,000 deaths as a total from just these 4, pneumococcal pneumonia, Hibs, typhoid, and GBS conjugate. And that's just, and if you expand coverage, you get more. And so the total achievable, like I said earlier, is about 170, 180,000 deaths that you can avert. Now, again, like I said, there's vaccine opportunities for development, and this is where a lot of the innovation is really worthwhile. There are licensed vaccines already, but a lot of candidates that we need to get into. If you look at water and sanitation, now here it's very interesting because hand washing is really a very important part of this entire story. But you have water and sanitation diarrheal disease deaths, and you look at the number of deaths in thousands. If you look at all wash deaths, that's about, that's a large number of deaths, as well as, simply through hand washing avertable, that's about 45,000 deaths right there. All wash is about 51,000 deaths. And that's just in low-income countries. And you have similar numbers or even higher in low-middle-income countries and upper-middle-income countries. Obviously, if you take all LMICs, that's about 183,000 deaths that are avertable just from all wash. And this is what the coverage of basic water and sanitation services does. It's a bit challenging because if you look at proportion of all deaths avertable, if you have some of these components of WASH, you don't get that reduction. Each of these represents a study. But when you get a significant number of these water and sanitation services happening, then you can reduce a large proportion of deaths. So WASH is not linear in effect size. You really need to have significant coverage in order to see results. It doesn't happen just from having one or two interventions. And again, here, if you look at IPC, you can increase IPC compliance by 20%. And here again, there's a large number of deaths that are avertable. You can compare these across. IPC has a significant impact. WASH has by far the highest impact here in low-income countries, and then vaccination. Slightly different in LMI in low and middle-income countries where IPC and WASH have similar effect sizes, because by that time WASH, there's not that much to avert there. And as you get further up the income chain, WASH has less and less of an impact. But overall, WASH and IPC, I would say, are pretty similar in terms of rates of AMR-associated mortality that you can avert, and then come vaccines as well. And these are the projections through to 2030. And mortality is one part, but the other part is antibiotic use. And you can see here that antibiotic use can also be averted. These are measured in defined daily doses averted in millions. And if you look at the summary figures, if you take out influenza, for instance, you still have a significant number of, you have about 1 DDD per person annually averted just from vaccines. But if you include influenza, that's more like 2. Just for comparison, LMICs use about 14 to 15 DDDs per person annually. So a 2 DDD per person annually reduction is roughly equivalent to about 10 to 15% reduction in antibiotic consumption. Now you add WASH also on top of that, and you can get a pretty significant reduction right there. So overall, this is what the summary looks like, which is, you just have to have 20% more healthcare workers practicing hand hygiene. You need universal WASH access, and you need universal pediatric vaccine coverage. And we can have some pretty amazing results, right there. And like I said, universal WASH averts about 11.5% of antibiotic use in LMICs, and universal coverage of vaccines averts about 14.1% of antibiotic use in LMICs. These are not necessarily additive, but they're not entirely duplicative either. So there's some overlap, but not entirely. So this again is back to the original number that I presented to you in terms of what is possible. What we proposed in this Lancet series was that the world adopt these 3 targets. Now, as it happens, the UN declaration, which was passed nearly a month ago, did adopt the 10% reduction in mortality from AMR, so that's in there. It didn't quite adopt the 20% reduction in inappropriate human antibiotic use, but it used a proxy for it, which was to have 70% of antibiotics be in the access category. So it is somewhat in there. The 30% reduction in inappropriate animal antibiotic use, it survived in the document for a long time, and then finally was replaced by language which said that inappropriate animal antibiotic use will be substantially reduced. Now, I'm hoping that substantial means that it's at least 30%, but then if there's not a number, then who knows? And just want to say that these 10, 20, 30 by 30 targets are well within reach using existing interventions. I think, we have the tools already to make these happen. And it's just a question of countries, doubling down to make sure that they're actually happening. So last couple of points are related to animal vaccines. So we're doing more on this right now. And the fundamental idea is simply that broader coverage of animal vaccines can have benefits for household well-being. That's obvious because sicker animals, lower productivity, higher veterinary costs, or risk of them dying, all of which have an impact on the household. The second is climate-related, and the climate-related one again is related to this first well-being idea, which is that if you're able to have more productive animals, and especially for livestock cattle, the same amount of methane may be expelled, regardless of the amount of milk that the cow is producing. But if they can be more productive or they stay alive for longer, then the carbon footprint per liter of milk or per pound of meat may actually be much lower. In fact, you do see that, for instance, the milk productivity of a cow in Ethiopia is probably a tenth of a cow in the Netherlands. And some of it has to do with the breed, but a lot of it also has to do with the quality of health that that animal is receiving. The third is, of course, animal welfare. And the last is human health benefits. Human health benefits come from two places. One is reducing the risk of disease spillovers from wild animals into domestic animals. We talk of a One Health approach to pandemic prevention. We've just never articulated this well enough to be able to say what the world needs to do. And if there's one thing that the world can do, it is prevention, it is vaccination. The second is really on antimicrobial resistance. Now, 70% of antibiotics in the world are given to animals for both disease prevention, but also growth promotion. And vaccinating animals can be one of the best ways in which you can reduce the antibiotic consumption in animals. And therefore, it has benefits both for the animals in terms of reducing resistance, but also for humans as well. So these were in a paper in Science that came out earlier this year. I'm sorry, I don't have the citation, but if you look by the name, you should be able to find it. If you look at vaccination coverage against Newcastle disease, what you see is significant difference in coverage between high-income and low-income countries, or even middle-income countries. The gap in vaccination coverage in animals is stunningly larger than it was even for human vaccines before entities like Gavi were introduced. And if you look at, say, paratuberculosis, if you look at reduced milk production per cow in liters per cow per year, it's a significant number because of disease. And if you look at the benefits for a global vaccination against bovine para-TB in terms of milk production, both quantity and value, the top was how much more milk you can get in liters per cow per year, what the value increase will be, but you also have a reduced emissions in terms of kilotons, in terms of carbon dioxide equivalents, which are benefits that accrue to the entire planet. So I think we need to focus on prevention, both in animals as well as in humans. And we have the tools in some cases, but we also need to develop more tools and make them widely available. So just wanted to come back to the UN declaration to say that we had an opportunity to set a bold and ambitious agenda that no one anywhere dies because of lack of access to effective antibiotics. And I again would reiterate that we really need to think about how we're communicating this. AMR is not understood by most people, but everyone understands the need or the right to have access to effective antibiotics. And that's what an independent scientific body is proposed for, to expand this evidence base. And there's also proposed for increased funding for these programs in both human and animal health. But unless we as practitioners keep the pressure up, this money will never really arrive. So I think we collectively have a lot of work to do to make sure that we actually move the needle on this topic. It's certainly the most important thing that is affecting global health today. And I say that with no hesitation because I think the numbers speak for themselves. So that's it from me. Thank you very, very much for listening.
Thank you. Really, thank you, Dr. Laxminarayan, for an outstanding presentation. Do you have time for one question?
Sure.
There is one person coming up to the podium.
Hi, my name is Kirsten Meyer. I'm from the University of Toronto. Thank you for a very thought-provoking talk. My question is if you could tell us a little more about the economics of vaccine development, especially for trying to target LMICs in this area.
I'm glad you asked that question because the economics of vaccine development have changed a lot with the introduction of Gavi. Because prior to that, we didn't really have someone who was ready to buy the vaccines, and today we do. But that said, we still need a significant proportion, we still need an impact to be shown on public health for these vaccines to be adopted by Gavi itself. And we no longer have these sort of blockbuster diseases like, pneumococcal pneumonia or rotavirus or, Hib, which make that decision easy. So in many ways, the element that moves the needle, even for Gavi, is the effect that a vaccine might have on antibiotic consumption and also on drug resistance. So I think that anyone who's developing a vaccine, if they pay attention to their effect size on this as collateral damage, which they might not have done 15 or 20 years ago, it might make the case for them, both at Gavi, but also within country for the vaccine introduction. We're working hard to make sure that vaccines are seen as a very central part of the agenda in tackling both AMR and all bacterial infections. But it's shocking how divergent these conversations are, and I think we need to bring the prevention conversation much more aligned. The challenge is that sometimes when people hear AMR and they say the drugs don't work, then the natural sequitur to any rational person is, well, then maybe we need new drugs. And I hope I've convinced you that that is not necessarily the way we need to go. For sure, we need new drugs, but there are many challenges on that pathway, and prevention may be a much more feasible pathway at a lower cost.